Hello, this is John Kanellopoulos from Athens, Greece, in New York City, New York. Very interesting case. This is the first eye, right eye related with a perfect DSEAK graft due to Fuchs. This is her other eye, just a few months after a DSEAK graft, her left eye. You can see a tremendous edema, both on the graft and on the host. A large epithelial defect. Our suspicion goes directly to HSV. This is a year later with a lot of HSV treatment. The options are limited here. So we tried to use a novel approach. We have a good DSEAK graft established by OCT, an ability to get endothelial cell counts, and you can see here that her host, her own cornea, is very densely opaque. So we're going to the femtosecond laser, the FS200. We're going to do a penetrating keratoplasty as far as the host cornea is concerned, but a deep lamellar keratoplasty as far as the whole eye is concerned, now with the DSEAK graft in place. You can see the treatment plan on the top right, and once applanation is achieved, you can see the actual completion of the femtosecond laser vertical incision, and we will go on to the OR and use a graft from a DELK case. So this is a whole cornea missing the endothelial side only. I'm tree finding 7 millimeters, 7.5 millimeters here. The femto was 7 millimeters because the original DSEAK graft was 8.5 millimeters. So what we're trying to do here is, as you can see, remove a complete incision of the host cornea and use the DSEAK graft as a safety valve behind the residual host rim, and fit then the tree-find cornea from that was left over from a DELK case. So one donor cornea, 2 recipients. You can see here with a 70-degree knife going in and completing the incision. And we can see now the surface of the DSEAK graft, the original DSEAK graft placed 14 months ago. And interestingly enough, you can see here that I'm picking up a small tag of Decimet's membrane from the original Decimet membrane that was supposed to be stripped during the original DSEAK procedure. This is the femto-created graft. There's a little bit of edematous. It's 2 weeks old, but it nevertheless doesn't matter because this is a patient that has very good endothelial cells from the original DSEAK case, and we're going to go in and suture this in place. We're going to use almost full thickness sutures on the second graft, this deep lamellar graft as far as the whole eye is concerned, and as I mentioned before, a penetrating graft as far as the patient's own cornea is concerned. So deep sutures here, and I can go flush with the DSEAK graft. To my surprise, a year and a half later, the adhesion between the DSEAK graft and the peripheral patient's cornea rim is very good. And I will go ahead, since there's a neovascularization of the host cornea and history of herpetic disease, and use 16 interrupted sutures instead of a running suture and 8 interrupted, which is my usual routine in corneas that do not have peripheral pathology. So the rest is quite simple. It is an easy penetrating keratoplasty as far as the host is concerned, because we're not open sky. We have a very nice valve created by the DSEAK graft, which holds our procedure watertight. You can see that the chamber throughout the whole procedure is maintained without a problem. You can note a little bit of bleeding at the 3 o'clock position. That's where I originally placed a paracentesis. So when I was removing the scored host cornea, not to have a full chamber and increased intraocular pressure and risk an eruption of the DSEAK graft. So we're in the final sutures here. You can see the knots are still out. All knots obviously will be buried. The question here is, with the DSEAK graft, the patient turned, or would have turned, to be about 2 to 3 diopters hyperopic, so I oversized this deep lamellar graft for the whole eye in order to achieve a little bit of a myopic shift. You can see the procedure completed. Very nice chamber. The graft is already clearing some moxifloxacin and dexamethasone with chloramphenicol, very common medications out here in Europe. And this is immediately after the procedure. You can see how the sutures compress the graft-host interface, and the good opposition. I was worried that there would be a fluid pocket between the original DSEAK graft and the cornea we just placed in, but it looks great. Thank you very much for your attention. I hope you enjoyed this presentation. This is John Kanellopoulos signing out.